we're going to have Dr. Lewis Roberts. He is from the Mayo Clinic in Minneapolis. We have been working with them for 4 years, helping to fund the information that's going in the patient registry there. He's going to talk with us just briefly about, you've seen the action alerts on the website, and I hope that if you can, you have participated in that. And he's going to share with you some of the data that has come out of that and just give us an update there. One other thing that we were asked to do is if you are a patient and you don't mind, please stand. Okay. The patients would like to know, yes, thank you, go ahead. Okay, if you have, some of the patients would like to know who has a similar diagnosis to them, so if you don't mind, if you do not want to participate, you don't need to. If you have intrahepatic, would you please raise your hand? Okay. Do you know if you have hilar? Hilar, okay. So can you see each other? Okay. And what about distal? Or extrahepatic, yeah. Okay. Hopefully that will help you connect as well. Also, of all the patients, we'd like to know who has had surgery. Okay, and who is non-surgical? Okay. Okay. All right, Dr. Roberts, please.
Thanks, Stacy, and thanks everyone for being here and for the opportunity to give a little bit of an update on some of the work we've been doing. So I can't remember actually when we first connected, but I think it's about 4 years ago. And our group has had a long-standing interest in biliary cancers. And I think this really stemmed from work that was done at Mayo in the 70s and 80s, where the group there took a special interest in primary sclerosing cholangitis, or PSC, that we've mentioned it is a risk factor, a major risk factor for cholangiocarcinoma. So over time, the hepatology group did a lot of work on the epidemiology, trying to understand what kinds of risk factors were associated with people transitioning from primary sclerosing cholangitis to the development of cholangiocarcinoma. They developed some risk models for patients with primary sclerosing cholangitis to track the progression of the disease. But in the course of all of that work, many physicians would refer patients with PSC to Mayo, and so we ended up with following a fairly large cohort of individuals. And one of the biggest challenges of following people with PSC then is that, you know, as Dr. Iyer mentioned, that a certain proportion of them will develop cholangiocarcinoma. We don't know upfront which ones will develop cholangiocarcinoma, and so it becomes a challenge to try to follow people in such a way that you can hopefully identify their cholangiocarcinoma if they develop one at the earliest possible stage. And then, of course, once you begin to identify those cholangiocarcinomas at the early stages, then the question becomes, is there anything you can do in terms of treatment with someone who you found has very early cholangiocarcinoma, which is really unique because most of the patients we see with cholangiocarcinoma often have no symptoms until they develop fairly advanced disease. So actually having the group of individuals that we are following with PSC gave us the opportunity because sometimes they would come in with an episode of cholangitis, some change in their disease. They would develop jaundice, and we would go investigating and find that, you know, they had what looked like a really small cholangiocarcinoma. And over time, the group ended up developing a protocol of liver transplantation that was actually first initiated by the team in Nebraska, and then subsequently modified by the team at Mayo for treating these individuals who have relatively early and typically perihilar cholangiocarcinomas that develop. So as I was completing my training and deciding on what I was going to focus my work on, I ended up deciding to focus on the genetics of the liver and biliary cancers. So I studied both hepatocellular and cholangiocarcinoma. And we began a registry, and it's sort of an interesting story there, because when I first started, I was looking for tissue to do basic biomedical studies on liver cancer. And one of our surgeons, who's been, is one of our senior liver and biliary surgeons, came up to me fairly early on when I was just starting as an assistant professor, and he said, several years ago, a couple of us surgeons decided that the solution to treatment of liver and biliary cancers was not going to be in the operating room. And so we decided that we were going to begin to save pieces of the tissues that we were resecting from patients. And so this was him and one of the breast surgeons. They bought a freezer, they put it in the frozen section room, which is where all the tissue goes immediately after it's taken from patients. And they told the technologists in the frozen section lab, every time we do a surgery for someone with cancer, please freeze a portion of this tissue in the freezer. For the physicians, no IRB, no consent form. So it's kind of, it was in the dark old days of biomedical research. But the interesting thing, of course, was that then when I came along and said, I'm looking for tissue to study, they had already about 10 years worth of tissues that they had saved. And that was really very helpful for me initially in getting started. And so that was, I think, for me, the genesis of the idea, if what they did could be so helpful for my work, how much more helpful would it be if I started then in really the right way, getting IRB approval, getting consent from patients, and developing a patient registry and biorepository. So starting in about 2001, we started the initial registry and biorepository. When we first asked the IRB, they said it's okay to get oral consent, verbal consent from patients, as long as you document it in the medical record. So for a couple of years, they let us do that, and we still have these documentation things in the medical record of patients agreed that they'd be happy to, give samples, blood samples, and so we send them off to the lab. And then a couple of years later, the IRB came back and said, no, you can't do that any longer. Now you need a formal written consent. And of course, it's like every couple of years, they add more things that you need, more rules about that. But the thing that's been extremely helpful then is over time to be able to develop additional collections of specimens. And we've collected specimens not just from the tumor tissue so that we can study the tumors and better understand what it is in these tumors that is driving the growth and the metastasis of biliary cancers. I mean, you've all probably heard that biliary cancers happen to be some of the most metastatic of all cancers. And so trying to understand, what the basic biology of that is the work that many of the scientists that will be here for the rest of this meeting are working on. And having those tissues has been extremely helpful in doing that. The other thing that's been extremely helpful in the last few years has been the realization that we can take tissue from a patient and put it in a mouse that is immune deficient, and that tissue will grow, not all the time, but a good proportion of the time. For cholangiocarcinomas, we're up to about 60 to 70% of the time. We can take tissue out of patient, put in a mouse, and it'll grow. And what that allows us to do is really begin to then very carefully examine the growth characteristics of that tumor, the sensitivity of that tumor to different drugs, to new drugs as they become available. And that's become a whole other area of study of these tumor tissues. The other thing that the National Cancer Institute has been doing over the past about 10 years is a project that they call the Cancer Genome Atlas Project. And so this stemmed from the idea that, at the same time that we know that, breast cancers are breast cancers, the minute you begin studying breast cancers, you begin to realize that there are many different subtypes of breast cancer. And even within the subtypes, there are subtypes. And at a certain level, each cancer is its own thing. And so what the Cancer Institute began to do a number of years ago was say, okay, why don't we begin to use some of these new sequencing technologies that we have for genes and begin to sequence tumors? And they started out with the most common tumors. So they started out with lung and breast and ovarian cancer. And then about maybe 6 or 7 years ago, they expanded it to the 25 most common cancers. So that included the primary liver cancer, but not cholangiocarcinoma. And then about 4 years ago, they said, well, we have a little bit of money here. We're going to open up for the rare cancers. So we did a big lobbying effort to try to get cholangiocarcinomas in that mix, and we were able to get them to assign a cholangiocarcinoma project as well. And so over the past year or so, there's been a group of scientists around the country that have been examining the data from, we actually ended up with about 36 samples that met all the criteria that the TCG had. And we had about 15 samples that didn't meet all the criteria, but that we thought we could still learn some things from. And we were fortunate in that the Cholangiocarcinoma Foundation actually partnered with us to pay for some of that sequencing. And we're in the middle of trying to validate the results of that sequencing. So we hope actually within about a month to be submitting the publication that will include data from about 50 samples that have been analyzed. Clearly still a relatively small number, and you can imagine that there's much more that we would like to study in the case of the tumors. The other thing I wanted to talk about, though, before I finish with tumors, one of the other things that we've learned, and I think that oncologists tell us about a lot, is the fact that tumors change over time. So, you have a patient that comes with an advanced tumor. You start them, we've mentioned gemcitabine and cisplatin as a common standard of care. You start them on gemcitabine and cisplatin, and they might have an improvement, a reduction in the size of the tumors for a period of time, but then sometimes the tumors begin to show signs of resistance, and they might start growing again. So some things change in the tumor, or we've selected out a subpopulation in that tumor that is resistant to gemcitabine and cisplatin. And so, of course, the next step that we sometimes do is we go and we get another biopsy of that tumor to see, can we learn more from another biopsy that helps us to decide what the best way is to now treat the patient. One of the advances that has come about in the last several years is the concept of liquid biopsies. So this is the idea that these tumors, because they tend to have this tendency to metastasis, tend to shed cells into the bloodstream. And so if you have techniques that are sensitive enough, you can do one of two things. There are now techniques that you can actually sift through all the cells in the blood and find the tumor cells that are floating in the blood, the few tumor cells, and study those individually. Or you can look for the DNA that is released from the tumors, what we call circulating tumor DNA, and study that. And so there's a number of groups now that are actively performing studies using blood samples from patients to try to follow and track the evolution of a disease over time. And that's one of the studies that we've started, and I just wanted to mention that. So if you happen to have a cholangiocarcinoma and you happen to have had already some kind of genetic testing of your tumor, Foundation 1 is a common one that people have had. There's a number of different types of select panels, and you have any interest in participating in one of these studies to look to see how well we can detect the changes that we are seeing in tumors in the circulating blood, please come see me, and we'll be very interested in having you participate in a study that particularly is looking at that. And the idea is that if we can reliably detect the changes in the tumor, hopefully over time, we don't have to keep going back to people for biopsies. We may be able to have techniques that are sensitive enough that we can just get a blood sample and be able to track the changes in the tumor over time. So in terms of tumor analysis, those are, I think, some updates and some things that we're excited about continuing to pursue. In terms of the question that we had in the other session, 5 minutes? 2. Okay. So we did talk a fair bit about the Genome-Wide Association study because we had the question in the earlier session, and I just wanted to highlight that again, that we're very interested in determining if there is inherited risk for cholangiocarcinoma, and the way to do it is to have as many samples as we can from patients and to compare that to DNAs from people who are unaffected. For some cancers, we are up to analyzing DNAs from 50,000 patients and more. So for breast cancer, for example, over 50,000 patients have been studied by these methods. The more patients you study, the better a sense you get of what the inherited genetic component is. So if for breast cancer, they think they can account for about 20 to 30% of a person's risk by inherited predispositions that they've identified. And so we're just starting at the beginning. We're trying to get 2,000 samples, and I mentioned earlier we have somewhere around 1,700 to 1,800 samples. So please let us know if you're interested. We'd be very happy to enroll you into that study as well. No, stop there. Thanks.
Introduce our next speaker, but I just want to let you know we've had such a great relationship with the Mayo Clinic, and especially with Louis. Louis's mother died from cholangiocarcinoma, so he has a personal interest in this research. And what he's talking about is all of those things are on the website as well, so you can, if you want to participate in the studies that we're doing, the information's on the website as well, or you can talk to Louis.